Madam. Over to Dr. Naina Hyder, Madam, for her talk on pseudomyopia, diagnosis and management.
Good morning to you all. I see we have a big crowd, at least for myopia. And my topic today is pseudomyopia. It will throw you off guard because we've been discussing myopia so far. So I have been tasked with pseudomyopia. So coming to a clinical scenario, we usually sometimes do get these type of patients, like a 10-year-old boy who had defective vision for distance in both eyes, was not able to see the letters in the whiteboard in school and eye strain, brought in by the mother, anxious mother, and the best corrected visual acuity was -5 diopters, and he gave a 6/6 correction, cycloplegic refraction. We usually in our setup we do a homotropic refraction, and that came as +0.5. And the refractionist who's with me came and told me, "Madam, this is the refraction I've got." And I looked into it, and there was no strabismus. And the refractions was telling the accommodation was active during retinoscopy. The pupil size was keeping changing. The accommodation was intact. So I did order in a tropin refraction, that is with an ointment. We usually do give eye ointment because the mother was anxious. I didn't want to have any allergic reaction. So anyway, we did atropine, and to do us this, it came as +0.5 diopters. So this all attributes to accommodative spasm. So this spasm was described by von Graefe in 1856, pseudomyopia or spurious myopia. And here the tone of the ciliary muscle is increased. The power is there. The far point and near point are closer, but the muscle is unable to relax. It's all held up with the biceps and the muscles together. But the changes in the refractive error is towards myopia. That is, you get when you have a hypermetropes, they become less plus, myopes become more minus, emmetropes become also minus. This is the shift you see in pseudomyopia. But as the earlier speakers has told, the axial length, whereas in progressive pathological myopia, in pseudomyopia, the axial length is going to be normal because the hypermetropic refraction will be +0.5. And when you do a corneal curvature, doing a keratometry, the corneal curvature is also going to be normal. So that is going to give you the diagnosis of are we dealing with a pseudomyopia, because we won't have a change in the axial length or the corneal curvature for the age. And usually these patients come with blurred, distant vision, macropsia, anisotropic symptoms, headache, eye strain. The diagnosis is usually that the child or the adult will eat up the minus lenses, because if you give 0.25, 0.5, they just go on accepting, so happy to accept more and more. And there will be a variable objective and subjective refractions in these patients. The range of accommodation will be abnormal for age. The fogging test, sometimes the refractions do them, but they cannot relax the accommodation because the patient keeps on eating up the minus lenses. And the pupil size, the meiosis is there. You can see the changes in the pupillary size. The variability with the weaker cycloplegics. Sometimes you do get esotropia, which is can be plus or minus in these patients. And coming to the types of pseudomyopia, it is divided as functional and organic, that is Duke Elder. So the functional pseudomyopias are common. They are in school-going children, adolescent, young adults, pre-presbyopia. So you don't have that myopia in the child. You do have it around the range of the population. And you do get it in intermittent exotropia, has also been said to have a pseudomyopic element to it. Convergent insufficiency also. So these are the factors you have to look into a patient with myopia: the axial length, corneal curvature, the accommodation, the pupil size. So convergence, everything has to be looked into it. Myopia, as we all talk about it, but there are so many factors we do have to keep when we have a patient with myopia. And treatment for functional myopia is sometimes difficult to treat. The corrective glasses are given with the correction of astigmatism because we have to relieve the child or the adult with the glasses. We are forced to give the glass. And visual rest is advised. A person's encyclopedia 3 to 4 weeks with hometropin once or twice daily may be required, and sometimes even a period of atropinization may be needed for months. And a +3 or you have to, because the child will be having difficulty with near vision, so a +3 +2.5 glasses has to be prescribed for near also. And coming to organic pseudomyopia, it is a rare. You can have it in myotic drugs when you have pilocarpine for glaucoma, uveitis, uveal effusion syndromes. There are a lot of lists of organic pseudomyopia, and overdose of morphine, digitalis, brainstem lesions, encephalitis, fevers, diphtheria, sulfonamide. So lots of studies, lots of papers have coming with, there was a paper on whiplash injury causing pseudomyopia, head injuries. So there is a chance in these patients to have a pseudomyopia. So to conclude, it is stressful to the patient and doctor. The patient keeps on doctor shopping. We do get these type of patients in. They are not satisfied. The parents are anxious. And sometimes you do order in a full neurological workup in these patients with neuroimaging, because we are not sure, are we dealing with functional or organic? But when we went back to the history with this 10-year-old boy, he came up with, the mother was reluctant initially. His father has passed away recently. The mother was handling all the load as a single parent. The child was stressed. So he was accommodative spasm. And we need the child to, get accustomed to the environment. So we need to sometimes go into details with the family, with the parents to know about all this. And so the need of atropinization and bifocal spectacles is advised, and treatment may prolong for months to a year or more. So to conclude, pseudomyopia has to be looked in patients with myopia also. Thank you.
Thank you, ma'am.